Nerd here. Hey, what's up? So we're going to talk today about salt. Talk about sodium. This is like one of these subjects that are so confusing and complicated, and the test, the board's USMLE is going to try to trick you and make you confuse diabetes insipidus with SIADH and hypernatremia, hyponatremia. You're going to be all over the place. What I'm going to do today is make this like ridiculously simple. At least I'm going to try. We're going to start with hypernatremia, and then we'll get on to hyponatremia, but let's jump right in. So just to jump right in, here we go. This is how simple we're going to make this, okay? The human being in its simplest form, human being is, oh no, I don't want that circle. Take that back. Human being in a simple form is a bucket, okay? Here's your bucket. That's more like a bowl, but just bear with me. Just pretend for a moment. And this human being, yeah, it has emotions and aspirations and dreams and all that stuff, but it's really just a bucket of stuff. And it also has two spouts. Conveniently, this human being actually has two spouts. And what's going on with this human being and those two spouts is it has one spout, which is for sodium, which today we're going to just say Na. And then this human being has another spout, which is going to be for it to get rid of H2O. So that's it. This is a human being, and inside this bucket is also stuff coming in. What do we have coming in? Well, guess what? We've got two things coming in, and you guessed it. One of those things that is coming in is actually going to be sodium again. We have sodium coming into the bucket up here. And then we've got H2O coming into the bucket. And that's it. That's everything you need to know about a human being. Just kidding. But that's everything you need to know about a human being for your STEP exam. Pretty much. We'll add a few other little things that will help make sense of this all. But there's actually, there's a safety mechanism. Because if we get rid of sodium and then we're like, wait a second, actually I wanted that sodium, there's actually a way to have it come back into the human being. And if we get rid of too much H2O and we're like, wait a second, I actually want that H2O, so I have a way to kind of bring it back in and say, hold on 1 minute, let's take some of that H2O back into this bucket. So that's our human being. That's the bucket that we're talking about. And inside this bucket, we have got all these little sodium particles. Sodium, and it's floating around. Those are beautiful particles of sodium. I've never seen such beautiful sodium particles. They're floating around in this bucket of water. So here we go. What I'm referring to here, so sodium leaves the body, kind of. I'm saying that just for simplicity's sake. Leaves the body, and then we say, hey, wait a second, we want that sodium to come back. Is there some type of a molecule or hormone which can say, hold on, we want the sodium to come back? Fill in the blank. You guessed it. It's aldosterone. Aldosterone is that hormone that says, wait 1 minute, we might want the sodium to come back in here. And is there some kind of a hormone or molecule that allows the water to come back in and say, hold on 1 minute, I want that water to come back? Well, water leaving the body is diuresis. So maybe it's like a molecule called anti-diuretic hormone. I'm just guessing. ADH, also called DDAVP, also called vasopressin. Just memorize that. So it's interesting, you'll hear people say, well, for the STEP, you got to just memorize it. And some people will say, no, you have to just understand it. You don't need to memorize anything. As long as you understand it, you'll do well on the test. Because if you're just memorizing, then the test is going to try to trick you, and they'll ask you something in a new way that you never thought of. Okay, guys, both are true. You absolutely need to memorize a ton of information. You need to remember that ADH is also called vasopressin, and it's the same thing as the drug called DDAVP. But you also need to understand what's going on. So both are true. So anyway, here we are. Here's this human being, and this human being is just doing great. And we had sodium, and we really have kind of 6 things going on here if you think about it. I'm going to show you what those 6 things are. Here we go. What we have here going on is we've got sodium coming into the body, which I'm circling in green, okay? Then in addition to that, we've got water leaving the body, which I'm circling in green. And then in addition to that, we have aldosterone here, number 3, Whoops, am I able to change that shape? I can't change the shape. Okay, you get the idea. We've got aldosterone over here, which is number 3, which is telling sodium to come back into the body. So we've got number 1 over here, sodium coming into the bucket. We've got number 2, H2O leaving the bucket. And number 3, aldosterone telling sodium to come back into this bucket. Okay, and those are all circled in green very conveniently. And here we're going to have pink circles. And we've got H2O coming into the bucket. We've got sodium that's leaving the bucket over here. And we've got this antidiuretic hormone, which is telling water to come back into the bucket over here. So we've got 6 things going on. 3 of them are green, and 3 of them are pink. Does that all make sense to you? So we have 2 things coming into the bucket, 2 things leaving the bucket, and 2 hormones here that allow those things to come back into the bucket after they've kind of left the bucket. That is it, folks. That is a human being for you. You don't need to know much more because everything's kind of going to fall into place. So here we go. Now, when we're talking about sodium concentration, I answered my own question. When we're talking about sodium in the human body, what we're really talking about is sodium concentration. And what concentration means, you guys know this, but I have to just spell it out and say it. What we really mean is sodium inside of H2O. So we really mean how much, we're not talking about whole body sodium. If I ask you what's the sodium of this bucket, I don't want to know how many particles of sodium are in this bucket. What I really want to know is how much particles of sodium are there per liter of water that's in this bucket. So what we're really asking is for your concentration, which is sodium over H2O. And the way we measure that in medicine is your milliequivalents divided by liters. Milliequivalents of sodium in liters of H2O. Now you can see already, pretty intuitive, but I'll just say it, that for my sodium concentration to go up, there's really 2 ways to affect this equation. My sodium concentration could go up if sodium increases. That's the top part over here that I'm highlighting. Or if the bottom part of my equation decreases, all of a sudden I lose a bunch of H2O, then my sodium concentration will also go up. Okay? Does that make sense to you guys? We're going to go through this now. If you understood that, then you're going to understand everything else. I'm pretty sure you'll understand everything else. Just to mention it briefly, when we talk about sodium concentration, why do we care a whole lot? Like, who in the body cares? You know, like when we talk about potassium, who cares about potassium? It's really the heart. You know, high potassium, low potassium. The heart is unhappy when the potassium is not exactly where we want it to be. We can do a whole nother talk about that another time. But which part of the body is extremely unhappy when we start to mess around with sodium? It is the brain. The brain doesn't like those fluid shifts. So high sodium, low sodium. Normal sodium concentration, I should say, throw it in here, but normal sodium concentration is about 135 to 145 milliequivalents per liter. That's our normal. And then if it's low or high, the brain gets unhappy. What happens in medicine when the brain gets unhappy? Altered mental status, lethargy, coma, seizures, all of those things. Those are signs of the brain being unhappy, and pretty much it's the same for hyper and hyponatremia. The person is going to be altered in some way. They may have seizures. Seizures are more common with hyponatremia compared to hypernatremia, but both are possible. The test is not going to ask you clinically in the way a patient presents to differentiate between hypernatremia and hyponatremia because it will be very, very, very similar. So we're going to have to use our skills to kind of figure out what's going on with this patient. Now, today we are talking about hypernatremia. So we're talking about a patient who has a high sodium concentration, and this is going to be, we've got to underline this and make it look fancy. This is going to be a breeze. I hope it's going to be a breeze, okay? And the reason it's going to be a breeze is because we already know all this stuff, because we know that a human being is basically a bucket, and we know that there's only 3 ways, there's 6 things going on to this bucket, right? There's 3 green circles and 3 pink circles. And there's only 3 ways to affect our sodium concentration and make a person hypernatremic. And those are the green circles. Okay, number 1 is green circle over there in the top left corner, which is increase Na into the body, right? That's pretty straightforward. We're just going to say increase Na intake. And then green circle number 2 down there on the bottom right corner is loss we're going to number this number 2. Loss of H2O. I'll make the H capital to make it look all nice and fancy, and that's cool. And then number 3, what we got here is going to be number 3, as you can see, is aldosterone. Aldosterone, which is that thing, that molecule which says, hey, hold on 1 second, sodium, you're on your way out, but I want you to stick around a little bit longer. And here we go. Here's our numbering. Number 1 we said is over here. Number 2 we said is over here. That's your number 2. I'm just putting these little numbers in so you guys know what I'm talking about. And number 3 is right over here. 1, 2, and 3. It's our 3 green circles, and that is it. Every single time you ever get a question about a patient with hypernatremia, the answer is going to be one of these 3 things. They're taking in tons of salt. Oh, look at that. We got a pink line. They're losing H2O. That's your middle category. Or for some reason, they are increasing their aldosterone. So it's not that they're taking in too much salt, but it's the salt that they're already taking in is not able to leave, because every time it tries to leave, aldosterone kicks in and says, hold on 1 minute, buddy. Don't leave. We want you to stick around. That's it. So far, so good. I hope this is pretty straightforward so far. So let's talk for a minute about category number 1, which should be pretty easy. Taking in too much salt. What kinds of situations are that people take in too much salt? The answer is people who take in too much salt, people who eat too much salt. So the first one is going to be literally oral intake. And the classic case for this that you may have seen in like movies or TV shows, and you can get a board question about this, is like the teenage kid or the college kid who was dared to drink a thing of soy sauce. I don't know why that's like become a thing, but Google it. That is a thing. People like dare people to drink a can of soy sauce, and those people are doing something that's actually life-threatening. They are suddenly taking in a huge load, right? Soy sauce is very salty. They're suddenly taking in a huge load of salt. All of a sudden, the bucket over here has number 1, sodium coming in a huge, huge, huge amount. The brain is unhappy. The kidneys don't even have time to kick in, and the brain gets unhappy, and the person can have seizures, coma, and death. So very, very, very simply, that's like legit oral intake, nothing more to talk about. What we've got here as category number 2 we're going to call iatrogenic, which means the medical system is giving this person too much sodium. And the classic case of that is either somebody who was put on high sodium fluids for a bunch of days and they were forgotten about, or whatever, picture your scenario. But their test is going to give you some type of wacky situation like that. Or the other example you have to think about that test likes to talk about is the patient who was in cardiac arrest and got a bunch of, we call them amps of sodium bicarb. So like, this is not the topic today, but when someone's in cardiac arrest, they become acidotic. Often we'll give them sodium bicarb. This is an unresponsive patient, pulseless. They get tons and tons of sodium bicarb. It's a huge, we're giving it to them for the bicarbonate because they're acidotic. But as an aside, we end up giving them huge loads of salt. And if that patient does get return of circulation and they survive that cardiac arrest, they may be iatrogenically hypernatremic. And that's not a cool thing. I'm not saying we did anything bad. Saved the patient's life potentially. But that's the example of hypernatremia. So that's the simplest case. You have a test question and the patient has hypernatremia. The simplest thing is like, okay, was there a oral intake? And that's green circle number 1 in the top left corner. Okay, those are just 2 examples, but you can think of any other examples you want of increased intake of sodium or salt. Green circle in the bottom, this is confusing, I realize, because my lines are pink, but what we're really talking about is not the pink, we're talking about the green. So here's what I'm going to do. I'll make this green, no more pink. I want the green lines because we're talking about the 3 green guys today. Love that. Okay, loss of H2O. So this is the spout over here. For some reason, the bucket, which is the human being, is losing H2O. The sodium is staying exactly as it is. But remember, it's a concentration. So if we're losing water and our sodium is staying exactly as it is, then we end up in a situation with hypernatremia. What are cases where somebody will be losing water? Let's think about it. I'll give you a minute to think about it, but it's pretty straightforward. Anybody who is dehydrated, which is kind of just like a general term, they're dehydrated. Why are they dehydrated? So they're losing water, and we could think about examples like Whoops, coming right back here, we could think about examples like GI losses. So that's either stool or emesis. We could think about cases where they're also sweating, so the skin is having them lose H2O. So they're dehydrated for some reason. This will be like that classic patient with, like a stomach bug, so they're having tons of diarrhea, vomiting. Or this is going to be the patient, the other classic patient is this is the patient who went hiking for 3 days and they weren't drinking enough water. So they're losing tons of H2O in their sweat, right? Remember, sweat contains mostly water. They're losing, and we think it's salty, sweat like tastes salty, but it's actually huge amounts of water. So we're losing tons of water, and that patient becomes dehydrated. So that's the kind of thing we can think about. And the last example where we're losing kind of water through our skin is also the example of a burn patient. So a patient that has like massive amounts of burns, specifically second or third degree burns, that patient is going to be dehydrated. I'm using that term like, very loosely, but basically that patient is dehydrated. They're lacking hydration. So if this bucket is losing H2O, it's lacking hydration. The patient is either having vomiting, diarrhea, sweating, burns, and they're not replacing those losses quick enough. So they're not drinking tons and tons and tons. In the case of the GI patient with the gastroenteritis, obviously they're not able to drink because every time they drink, they might be vomiting it out. That patient is going to end up hyponatremic, not because they're drinking too much salt, but because they're losing too much water, because remember, it's a concentration. So far, I hope that everything I'm saying is pretty straight up, straightforward. Here is the one other case that I'm not going to say it's complicated, but it's mildly complicated, and that's what we're going to have to talk about. But the patient may be losing H2O in their urine. That would be the other case that I'm going to come back to in a second. So dehydration is like they're losing it in their stool or their sweat or something like that, or they're losing H2O in their urine, which we're going to come back to in one moment. I want to just get to category number 3, which is aldosterone is kicking in, so that's the green circle over here. Aldosterone is kicking in, and all the sodium that's trying to leave the body says, no, wait 1 second, you're coming right back in here. So the patient's not doing a soy sauce challenge and drinking tons of salty foods, regular salty diet, but the aldosterone is kicking in. Why would a patient have abnormal aldosterone? So this is primary hyperaldosteronemia, I believe that's the term. And the old school, when we used to name conditions after people, this is called Conn's disease. And what this is, I gave a talk on this, I think, another time, but where does aldosterone come from? It's from the adrenal cortex. I believe it's the zona glomerulosa. I think I'm saying that correctly. So if there's a tumor in the adrenal tumor, and it's secreting aldosterone, then the patient's going to have tons and tons of aldosterone. They're going to be holding on to tons and tons of salt inappropriately to the point that their sodium concentration is rising and rising and rising and rising. And how will you know if the test is kind of hinting towards this? How will you know if that's the right answer? A adrenal tumor or primary hyperaldo or Conn's disease, all of those mean the same thing. What will be the giveaway? So if you remember, aldosterone works on those channels, which aldosterone, yes, it hangs on to sodium, but what it does at the same time is it gets rid of potassium. You remember, it's like that channel where sodium is being held on to and potassium is leaving. So the clue for the patient with Conn's disease is going to be a patient with hypernatremia, like we said. The clue is going to be the patient, because he's holding on to sodium, he's also going to have large blood volume. He's going to have hypertension. So this is a patient with hypernatremia, hypertension, hypokalemia, low potassium. Because remember, all the salt that's being held on to at the same time, you're losing potassium at the same time. So that's your clue for category number 3. We'll also have a metabolic acidosis, most likely. But already we'll be able to answer this question. If they give you a patient with hypernatremia, hypertension, and hypokalemia, honestly, you can even take the hypertension out of the picture. If you have a patient with hypernatremia and hypokalemia, that patient has too much aldosterone. Legit. Almost certainly that patient is going to be having too much aldosterone. It's going to be Conn's disease. So that is it, folks. Like, that's it. I know this is sodium. I found it like super complicated, always, but this is it. Patient comes in, they give you some type of a question, and the patient's coming in, imagine, blah, 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 61-year-old male with blah, 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 fill in the blank, whatever you want, and then Sodium is 166 milliequivalents per liter. They give you some type of a story like that. Sodium is that high. All you have to do is think about these three categories, and you will get most of the questions right. And this is really not complicated so far. So number one, are they taking in too much salt? The story in the stem is going to tell you something like that. They may have been a cardiac arrest and got tons of sodium bicarb. They may have had some oral intake of sodium for some reason. Maybe they're on salt tablets. Maybe they're taking some homeopathic concoction that contains salt. That's going to be category number one. Are they category number two? They're dehydrated, so they're losing free water, either GI losses, sweat, burns, or through their urine, which we still need to talk about. I'm not done. I just want to leave that for last. Or do they have primary aldosterone, primary hyperaldosterone, which is Conn's disease? In that case, that patient is going to be hypernatremic, hypertensive, and hypokalemic. Okay, so I think that's cool, and I think that's a great start. And if that's all you got, and you take this and you stop right now, yeah, it's all good. I don't mind. But what we really need to focus on, and this is the part where people get scared, is this guy over here. Whoops, I wanted to make that as a drawing, not as a line. Let's make that a circle. Yeah, we got to focus on this guy right here. And what we have to focus on is what is going on in the urine. Kidneys are smart, right? Nephrologists are the smartest doctors because kidneys are the smartest organs. So why would the kidneys come and start getting rid of H2O, losing water to the point where my sodium starts rising and rising and rising and rising? Kidneys don't do that, right? Kidneys are smart dudes. So why are they doing that? They're taking this human being bucket and getting rid of free water. The first thing I want to say is, how do I know? How will I test? Or how will the USMLE tell me if it's the urine, if it's the kidneys which are causing my hypernatremia? Pretty straightforward, right? If we're talking about loss of H2O, so it's the kidneys that are getting rid of the water, then the urine is going to have lots of water. And there are two ways that the test will hint to that or tell you that. Either we'll say the spec grav, which is a test on a urinalysis, and this is, it's anywhere from 1,000 to around, I think, 140. And the higher the spec grav, the more concentrated. So if that the urine is, this urine is going to be dilute, right? You're losing water. You're almost having pure water coming out. So how will the test kind of hint to you that it's a urine loss? Is the spec grav is going to be very low. It might be 1010 or 1005 or 1005, 1010, something like that. So spec grav in this patient will be low. Or more likely, the test is not going to talk about the spec grav, but it's going to talk about the urine osms, and it's going to tell you that the urine osms, same idea, your osmoles, your particles in your urine are going to be very low because most of the urine is water. If this is a urine H2O loss, so it's this category right here, that's what the test is going to tell you, and most likely urine osms will be less than 600, but more likely they will be close to 0, let's just call it. But definitely your cutoff, you should remember, for the test is less than 600. So if it's a urine problem, the way the test is going to hint that to you is they're going to tell you that the patient is hypernatremic and the kidneys are the problem because the kidneys are getting rid of water. So that's it. If you have a hypernatremic patient with a spec grav which is low or a urine osms which is low, then you got to be saying to yourself, kidneys are not being smart in this scenario. What on earth is going on? And now the question is, well, why are the kidneys not being smart? Kidneys are supposed to be smart dudes. So here we go. Let's take a look. The kidneys are losing free water. Now, we know that if the kidneys have free water which starts to get lost, well, what's supposed to kick in and tell that water to come back into the body? Right, that's ADH. So why are the kidneys getting rid of free water? Or more importantly, I would say, the kidneys, they're getting rid of free water, but why is this hormone over here, ADH, which is supposed to be like our safety mechanism to bring water back in, why is that not working? So here we have really three categories of urine losses. So remember, you get this patient with hypernatremia, it's going to be 1, 2, or 3, one of these three categories. And if it's a urine, if it's this category, loss of H2O in the urine, they're going to hint it to you by giving you a spec grav or a urine osms. Both of those will be low. Now you have to start thinking, okay, something's wrong. The kidneys are not doing their thing. Well, option number one is this patient on a diuretic. Diuretics trick the kidneys, right? That's what they do. Remember, ADH is anti-diuretic hormone. So if somebody's taking a diuretic, then that tricks the kidneys, and the kidneys are not doing what they naturally want to do. Specifically, this will be something like a loop diuretic, like furosemide, something like that. Not going to get into it right now. It's a little confusing. Diuretics get rid of potassium. They also get rid of sodium. They also get rid of water, but it gets rid of more water than it gets rid of sodium. So if you didn't understand that last line, don't worry about it. But the bottom line is if somebody's taking a loop diuretic, they're losing free water. The diuretic is telling the kidneys to get rid of free water. They're going to have a low spec grav. They're going to be they potentially will be hypernatremic because they're taking a loop diuretic. Category number two is going to be an osmotic diuresis. And what this means is that there's so many other particles in the urine. For example, the classic case of this is hyperglycemia. There's so much glucose in this, and not in the urine, I should have said in the body, in this bucket. There's so much glucose in here that the kidneys are trying to get rid of the glucose. And what happens is, along with the glucose, as the glucose is leaving, free water leaves as well. So that would be like an osmotic diuresis, and the classic case of that would be something like hyperglycemia. And then the third category, which is the one we really have to focus on and talk about for a moment here, is the third category, is why would the kidneys not be holding on to water, or why are the kidneys getting rid of free water, causing the patient to be hypernatremic, and that is DI, diabetes insipidus. So confusing. If you're feeling confused about this DI and SIADH, it's confusing, but just remember, DI, what is DI? It's dilute. DI causes a dilution of your toilet. And you can imagine DI as a dilute igloo. I wish I had a picture. You know what? I'm going to grab a picture. Let's find a picture here of an igloo. We're going to do it. We're just going to do it. Igloo. Let's do igloo cartoon. And we're going to say, hey, let's get an igloo cartoon. There we go. Here's our igloo. Can I bring that back into my screen? Let's see if I can. I'm just going to do it because you're never going to forget it now. I know this sounds crazy and you're like, what is this guy doing? But just remember that igloo. Oh, I can't even bring it in. There it is. There's the igloo. Okay? So imagine the igloo is your toilet. You can kind of see that, right? I'm going to turn this upside down. It's a toilet bowl, okay? So you have a dilute igloo. That's DI. And just remember that and you'll never mix it up again. You'll thank me later. You'll thank me on test day. So DI is the dilute igloo. It's a problem where the kidneys are just getting rid of free water. What happens when you get rid of free water? Well, remember, sodium is a concentration, so your sodium stays the same, but you're getting rid of free water, so you end up with hypernatremia. Why are your kidneys doing that? This is the last thing I'm going to talk about, but we've got to remember this, and you've got to know this clearly for your test day. Why are the kidneys in DI? What happens in DI? Shouldn't we have this ADH molecule, which is like making sure that we hang on to free water and we don't get rid of free water? So either, where does ADH come from? Remember, I said it at the beginning. I believe I said it at the beginning. Did I say it at the beginning? I think I did. Aldosterone comes from the adrenal cortex. ADH comes from the anterior pituitary, comes down to the kidneys and tells the kidneys to hang on to free water. So I could either have central DI, where there's a pituitary problem. Think about something like head trauma or a mass or something like that. Central DI, it means there is not enough ADH, and therefore the kidneys are not being told what to do. So what are the kidneys doing? They're just getting rid of water because there's no ADH molecule. Or you could have nephrogenic DI, NDI. Remember, what is DI? It's dilute igloo because you're having dilution go into the toilet. And the toilet is an upside-down igloo. Or the upside-down igloo, yeah, you got it. Nephrogenic diabetes insipidus, which is where the kidneys, the pituitary is making ADH, but the kidneys, for some reason, are not responding. It's a kidney problem. They're not responding to the ADH, and the kidneys are just doing their thing, ignoring ADH. That's nephrogenic DI. Okay, those are your two things. So when we're talking about diabetes insipidus, we've got two different options. We've got central DI, and we've got nephrogenic DI. And the test, the last thing you got to know, the test is going to want to trick you and force you to figure out between these two. Which one is it? So you already discovered the patient has DI. How do you know? They're hypernatremic. You test their urine is dilute. Spec grav is low, or urine osms is extremely low. And you're thinking, it's not a loop diuretic, it's not an osmotic diuresis, this is DI. Now the test is going to want to know, well, how do you know if it's central DI, i.e. the brain, the pituitary is not making enough ADH? Or how do you know if it's nephrogenic DI? How do you know if it's nephrogenic DI, meaning there is ADH, but the kidneys are not responding? You know what you do? You do a test where you give that patient ADH, which is also called DDAVP. You'll give the patient a dose of DDAVP, and you'll see what the kidneys do. If the body was just lacking ADH because of a central DI, then when I give that dose, doctor comes and pretends it's the pituitary, right? I'm pretending I'm the pituitary. Here you go. I hand that bucket a dose of ADH. Then what should happen? The urine should start to change, and the body should start to hang on to water. But if the kidneys don't even know how to respond to ADH, it's a nephrogenic DI, then me giving that dose of medicine is not going to make any difference. Nothing's going to change because the kidneys themselves cannot respond to the ADH that's being given. That's the clue. That's the answer you have to know for the test. If you're thinking DI, you have to know how to differentiate between those two. Just to finish up, treatment. If somebody has hypernatremia, remember, you want to treat them with some type of fluid that will lower their sodium. So the simplest thing somebody might think to do is to just give them water, free water. That will rapidly lower their sodium. So if they come in, this patient here comes in with a sodium of 166, and that's the example you're given on your test day, and you're like, all right, and one of the answers is to give them free water. That is never the answer. You're going to correct it too quickly. Remember, high to low, brain will blow. If you hit a sodium that's high and you make it too low too quickly, the brain will blow. It's cerebral edema. The brain doesn't like all those fluid shifts. So you never want to correct it too quickly. You can give isotonic solutions. So if the sodium is 166, we can give normal saline. We're going to give it nice and slowly. We're going to be checking our sodiums all the time to make sure it's not going too quickly. The goal is about 10 milliequivalents per liter daily. So if you start at 166, I'm going to give myself 24 hours to get down to 156. So we're not giving free water and then quickly dilute it. We're going to give isotonic kind of normal saline. If the patient has DI, that's the underlying cause or issue, then we may just give them DDAVP as a replacement, and that should be enough. But we're only going to give them DDAVP if they have central DI, meaning their body's not making DDAVP. If they have nephrogenic DI, then the answer is not going to be DDAVP because the kidneys will not care if you give DDAVP. Nephrogenic DI means that the kidneys won't respond to DDAVP. I hope this helped you. I think this makes it somewhat clearer, and stick around. We're going to talk about some other cool stuff.